Wel- Welcome, guys, to another session that we're going to have on Easy Notes. So this is purely approach to an imaging station, but then now we are going to mainly focus on CT scan interpretation in general surgery. In neurology, it gets a bit complicated, but as an undergrad for surgery especially, it's important to know approach to an imaging station. Okay, so to understand imaging station, you need to understand that there are 6 main things that you have to look at on the brain CT. Okay, if you know these 6 things, you'll never get lost. Number 1, you start from outside in. You look at the soft tissue, which we'll go through very soon. Then the bone window will show you the continuity if there's any fractures. Then you look at is there any evidence of blood that you're picking up. Look at the brain parenchyma. The cisterns are just collection of CSF fluid in places where the brain is not. And finally, the ventricles. If you know this approach, you should be fine to approach it. All right, now let's start with soft tissue. Okay, so let's look at this CT over here. Okay, that's obviously the white part is the cranium itself, so it's the bone. So obviously what underlies the bone is the scalp. Okay, and the scalp, which has many layers, that is what you're seeing here. Okay, so that's normal scalp soft tissue. So if you see that it's increased, you think about soft tissue swelling, typically seen in head trauma. Okay, then the next thing that you are going to want to look at is the bone window. Okay, so when you see a CT in our setting, you always see the one with brain and this one. A lot of people don't know what this is. It's called a bone window. Okay, so what a bone window is simply an image that takes away the brain and just leaves the bone, so that, because remember this is too white, you may miss fractures, and so the bone window is really where you have to comment if there are no fractures. So look at the continuity of the brain CT that you're seeing on the bone window and say, okay, I cannot see any obvious fractures that I can pick up on a bone window, and that's really the use of a bone window. Okay, then you want to look at evidence of blood. Okay, blood typically in the brain accumulates in certain areas. Okay, the extradural simply means above the dura. Remember, you have the cranium first, which is the bone. Then we have a space called the epidural space just before the dura. Remember, the dura is the meninges. Then it has 3 layers, which is your dura mater, your arachnoid, then your pia. So this area just above the dura is called the extradural space. So if there's any bleeding there, we call it an epidural extradural hematoma. And just under the dura, just under this dura, which has 3 layers, you can have a collection of blood called the subdural. Then subarachnoid, remember subarachnoid is where the CSF is. Again, we'll see the pictures very soon. It can be in the ventricles, it can be in the brain tissue itself. Okay, so you have to comment on that if you're seeing. All right, then after you have ruled that out, you look at the brain parenchyma. Okay, how is the sulci and gyri? Remember, sulci is the depression, gyrus is the sulci is the depression, gyri is the ridges of the brain, because it's like that. So that's the gyri, that's the sulci. Okay, how are you seeing the sulci and gyri? So you can see here, you can see this normal sulci and gyri that you're seeing here, and you can see it very clearly, and so you have to comment on that. Okay, then again at the brain, you want to see, is there any obvious abnormal shift of the brain? Okay, typically the brain is like that, and you see the forks nicely there with your corpus callosum. Okay, are you seeing this normal line shifted? Now it's like this, what you call mass effect, because maybe there's a bleed here pushing the midline. Okay, which is very important, because these patients can herniate or you can compress the brain stem, which is where your respiratory cardio center is. So it's very, very useful to know that. Okay, are you seeing any obvious hypodensity? Remember, on brain scans, we don't talk about infiltrates like a CT, like a chest x-ray. We talk about density. Okay, so density, basically, if we say hypodense simply means that the area is dark. Okay, so black. Then hyperdense is to denote white discoloration. Okay, so let's look at this. You can see this area that is black here, we call it hypodense. Okay, and typically when you have black, it either means there is fluid, okay, which is our CSF, or it can be air, okay, which is, we'll see what it's called in a later, okay. But typically fluid is less hypodense than air, okay. So air will look like this. You see how black it is? This is air, okay. You see there also, that's air. That's very, very black, as opposed to this black that you're seeing here. It's less black. That's a CSF. So that's just some things that you have to take note in your brain CT. And hyperdense, as we have mentioned, is white, and typically when you see white is usually blood, okay. So blood typically enhances white on a brain CT, although there are masses and other things that can enhance as white, okay, especially calcification, tumors, but blood also you have to think about, okay. Now cystins, remember, I want you to look at this image. This is an abnormal CT, okay, because you're seeing white here. Remember, the brain CT is not supposed to have white in this area. This is supposed to be black because it's CSF that is supposed. So if you see white here, you must strongly suggest that it's likely blood that you see. But what I want to show you in this image is the cystins. Cystins is simply, you see the brain has indentation, is moving around the sulci and gyra. In those spaces, the CSF tend to fill those areas, okay. So those areas, those collections, those channels of collections are called cystins, okay. So there are a number of cystins. You don't need to know them. There is a suprasellar, there is an ambient, okay, there is a Sylvian fissure. But the key is that if you see that it's not black here, you have to strongly suspect, if you're seeing it's white, that is what you call a subarachnoid hemorrhage, okay. Though that's useful to know, okay. Then the ventricles is what you have to comment on, and you say, okay, are you seeing any obvious bleeds in the ventricle? Are you seeing them dilated like in hydrocephalus or ventricular effacement? So what we have discussed now is just the approach, okay. So here is how I'll look at the head CT. If you're saying interpret this head CT, okay, you see, you start from outside. We have talked about number one. Of course, you start with the biodata. This is a 47-year-old Mr. Who with a head CT taken on the what, okay. From outside in, the soft tissue appears to be normal. There's no obvious soft tissue swelling. Then you come to the bone window. Then the bone appears to be continuous. I cannot appreciate any obvious fractures. Then you come to the, are you seeing any obvious blood? I cannot appreciate any obvious blood in the extradural subdural space or the intraparenchyma. Then you come to the brain parenchyma itself. Are you seeing any of, there's no obvious blood, there's no midline shift, there's no effacement of the sulci and gyra. You see, we are commenting on the brain parenchyma. Then you come to the ventricles. The ventricles are not dilated, appear to be normal size. There's no bleeding in the ventricles or abnormalities seen. And finally, you look at the cystins, okay? This image does not have the proper cystins because this, remember, that's the lateral horn of the lateral ventricle. That's the temporal horn of the lateral ventricle. Then that's the third ventricle, okay, that you're seeing here, okay. Otherwise, when you look at another area, perhaps if this was normal, you say the cystins appear to be patent. There is no effacement of them. There is no blood that I can appreciate, okay. And thus, this is a normal head CT. That's how you interpret a head CT, and you should run through very fast, okay. Now, in the absence of everything, let's look at some abnormal head CTs. All right, what are you seeing on this head CT? Okay, you're seeing this an obvious, what you call convex. So that's convex. Okay, so you say, I'm seeing, remember, head CT, when you're looking at it, this is the right, this is the left. Okay, it's swapped, okay, because it's taken from your feet up. Okay, so I'm seeing an obvious hyperdense, because it's white, hyperdense convex shaped. Are you seeing that convexity that you're seeing? Hyperdense lesion in the temporoparietal. That's the you see, that's the frontal, that's the temporoparietal region. This is the occipital area. So in the temporoparietal left hyperdense lesion, and this, ladies and gentlemen, is what we call an epidural hematoma. Okay, typically we know that it doesn't cross suture lines, and it's typically because of an arterial bleed. Okay, this is a very dangerous bleed, and arterial bleed being mainly the middle meningeal, and that's what you're seeing here. Okay, typically these bleeds are in young to middle-aged people. Okay, and these are usually emergency, typically associated with a depressed skull fracture of some sort, because this is an artery that is bleeding, and so it will just keep bleeding. And you can see obviously that there's a midline shift. That line is supposed to be nicely in, but you're seeing that there's a midline shift, and those are all features. And there is effacement. Effacement means loss of the ventricles on the, mainly on the left, that you're seeing here. Again, you can see there is no sulci and gyra that you appreciate here, with cerebral edema associated, which we'll look at very soon. And so this is an epidural hematoma, and this patient needs for emergency evacuation of that clot, so you do an emergency craniotomy. Okay, so that's very, very important to know. All right, now what are you seeing here? You're seeing, again, I'll just point out the key thing here. There's a hyperdense lesion extending all the way from the frontal through the temporal parietal and almost reaching the occipital aspect of the brain on the right side. Okay, it's a right hyperdense, and you're seeing it's very elongated, what we call lenticular. Okay, lenticular shaped hyperdense lesion in the right, extending from the frontal aspect all the way to almost the occipital region. This is what we call a subdural. Okay, and you can see it crosses the suture lines. That's a subdural hematoma. Okay, typically is due to rupture of what we call the bridging veins. Okay, so it's a venous bleed. Okay, typically seen in the elderly or in very small children. Okay, and this may be or may not be an emergency depending on the setting. And perhaps what I can add here is that, okay, so you're seeing the dura there, which is your dura, and subdural, sub below the dura, just between the arachnoid and the dura. That's where you have the subarachnoid space, and that's what you're seeing there. And perhaps what I want to add here is that subdural hematomas can either be acute, subacute, or chronic. Okay, acute blood shows up as hyperdense. That's what you're seeing as a white discoloration, hyperdensity that you're seeing there. As time goes by, the enzyme will start digesting this, and so it starts mimicking. You're seeing here, it starts mimicking the normal brain. You see, you can't even tell the normal brain from the bleed anymore. So I call it isodense. Okay, and that's typically anywhere between day. So that's typically within 1 to 7 days, then that's around 7 to 14 days, then this is above 14 days. Okay, so you can kind of tell how old this, in fact, this bleed is. And finally, by the time it's chronic, it's completely hypodense. Okay, hypodense, remember, it means darkish, and so that's where you're seeing a hypodense lesion that you're seeing. All right, now, remember, what we talked about hypodense. Okay, hypodense can either be you are looking at CSF, which is fluid, or you are looking at air. Okay, you are seeing this black is the same black as this. This cannot be CSF. This is too hypodense. So you are saying a very hypodense area in bilaterally, particularly more in the frontal aspect of the brain. However, we are seeing also a patch of area in the occipital area of the brain. Okay, and so when you have this black, you are looking at air, and we call it pneumocephaly. Okay, pneumocephalus. Okay, typically seen in traumatic patients or other infections that may be air forming, and typically we manage it with 100% oxygen. Of course, there are other things that you saw. Please speak up. This is typically associated with trauma or some kind of infection that produces air. And so that's called pneumocephalus. Typically, we give 100% oxygen in this. All right, let's move on to this. Okay, what are you seeing here? You see there's no normal sulci and gyra. Okay, you see the normal sulci and gyra as we have seen in the normal head CT. Let's just look here. You see there, you can see sulci and gyra. But in this head CT that we're seeing here, we cannot see the normal sulci and gyra. And so we say there is effacement. Okay, effacement of the sulci and gyri. Okay, and so that, ladies and gentlemen, is what we call cerebral edema. Okay, which means the brain is swollen. Okay, so it's filling up all those spaces because it's swollen. That's why you're not seeing the normal sulci and gyri. So this is generalized cerebral edema. Okay, and it has to be managed. Now, the sulci and gyri were effaced. What happens when you see them too much? You see that's too prominent, the sulci and gyri. So we say prominent sulci and gyri, which is the inverse there, which means it's typically what we call cerebral atrophy. Okay, so the brain tissue is starting to become atrophic, whether it's a chronic alcoholic or you see it as the patient starts aging, elderly, the brain starts shrinking. You see there is now more pockets of CSF that you're seeing, and the brain tissue is a bit atrophic, and there's this prominence of the sulci and gyri. It indicates that there's cerebral atrophy. Okay. Now, what are you seeing there? Obviously, you are seeing that this ventricle, and particularly this the lateral ventricle, they are very dilated. Okay, so dilated ventricle is a sign of what? Is a sign of hydrocephalus. Okay, we are seeing the sulci and gyri are there, so they are fine. However, we are seeing this grossly distended lateral ventricle, that is hydrocephalus until proven otherwise. And perhaps just to run through other features of hydrocephalus that you are going to want to know. Number one, you can look at the temporal horn. Okay, perhaps I should explain. The lateral ventricle is actually a C-shaped ventricle. Okay, then you have your third ventricle here, then there's aqueduct, then the fourth ventricle. It's a C-shaped organ. So you have your anterior horn, which is on the anterior aspect of the brain, then your temporal horn, which is on this on the occipital aspect of the brain, the posterior part. Okay, so when you see the temporal horns, which I'll show you now, okay, so there, that's the anterior horns of the lateral ventricles. Okay, then this is the temporal horns. Okay, temporal horns. Then this in the middle is, as you are seeing it in the middle here, is the third ventricle, then the aqueduct of Sylvius, then the fourth ventricle. Remember, lateral ventricle empties into the third ventricle through the aqueduct of Monroe, then the third ventricle empties into the fourth ventricle through the aqueduct of Sylvius. The lateral ventricle is the anterior and the temporal horn, and that's what you are seeing there. Okay, so normally on a head CT you are not supposed to see, or barely only seeing these horns. Okay, you are normally not supposed to see these horns. So the moment you see them, and typically they say greater than 2 millimeters, some say greater than 3 millimeters, you have to strongly suggest to think of hydrocephalus. Okay, another thing that we normally do is what we call Evans index. Okay, Evans index is simply you measure this, the ratio maximum width of the frontal horns, as you're seeing them lined here, divided by the maximal internal diameter that you're seeing here, of course at the same level employed in the axial CT. Okay, so if you take this over this, and if it's greater than 0.3, then you have hydrocephalus. Okay, another quick thing that I will mention again, a feature of hydrocephalus, is what we call Transepinedemia Fluid. You see this area, see the ventricles are grossly dilated, but you are seeing these patches of hypodensity just surrounding the ventricle, periventricular hypodensity that you are seeing here. That simply means, remember this is the brain parenchyma, this simply means that fluid is now, because of the pressure, starting to leak into the parenchyma. Okay, so interstitial cerebral edema, okay, that you are seeing here, that's a sign of hydrocephalus. Transepinedemia fluid shift, okay, that you start seeing it shifting from the ventricle into the parenchyma. Okay, and another thing that you may want to know about hydrocephalus again is it may show a Mickey Mouse sign. Okay, where you're having, you see these the anterior horns of the lateral ventricle, and what's in the middle is the third ventricle, and then this is the temporal horn. You see them grossly dilated like that, you have to think about hydrocephalus. And finally, the moment you have rounding of the third ventricle, the third ventricle is supposed to be slit. Okay, the moment you see it round like that, again, those are features in keeping with hydrocephalus. All right, that should have been very helpful. Okay, what are we seeing here? We want to look at the bone window. Okay, look at the bone window. We're following. Oops, we see a fracture there. But this, what kind of fracture is this? We are seeing it's going into the brain tissue. Okay, when a fracture starts going into the brain tissue, it's called depressed. So you say, I can see an obvious depressed skull fracture. Okay, so that should be very easy. Okay, and then look at this. What is here? Those are the ventricles that you're seeing them in phase. There is obvious cerebral edema here because there is poor sulci and gyri. They are effaced. You can see it. And what are you seeing? What do you see it here? You're seeing a hyperdense lesion. And what's a hyperdense lesion going to be most like? It's blood. Okay, but it's in the brain tissue itself. So we call it intraparenchyma. Parenchyma simply means brain tissue, or intracerebral hemorrhage. Okay, so that's an intracerebral hemorrhage. And then what is the diagnosis here? I think we have seen this hyperdensity seen in all systems. So you're seeing that's a Sylvian system, that's a suprasellar system, quadrigeminal system. You're seeing all this hyperdensity. That's what called subarachnoid hemorrhage. So that's very important to know. Okay, then just so that we conclude, I just added this is really internal medicine. Remember, the brain, typically that's where you have the internal capsule, that's the external capsule. In this area, that's what we call the basal ganglia. Okay, so what I'm trying to show you here, it's definitely definitely in the brain. However, that area is what called the basal ganglia. So if you see a hyperdensity here, you have to think about hypertensive bleeds. Okay, hypertensive tends to bleed in two areas, particularly the basal ganglia, the pons, the ventricles, and the cerebellum and the so you have to think about hypertensive bleed. Typically, these bleeds are managed by neurologists. They do not go for any surgery because of the depth of the area. So this is a classic basal ganglia hypertensive bleed that you may need to know. So that's just for bonus reasons. Okay, and the second last thing that I'll add here, are you seeing this brain CT? What are you seeing here? There's definitely you see a normal head CT, you're supposed to see let me just show you here. Yeah, you see, you can see nice demarcation. You can see the white area, the white area and the gray matter. So you see the white and gray matter differentiation. You can clearly see it demarcated. Now, what are you seeing in this head CT? It's almost as if someone painted. It's almost as if someone just spread his hand and the whole brain just looks very homogeneous. Okay, so we call it this loss of white to gray matter differentiation. Okay, sorry for this. So white matter, loss of white matter differentiation. You can't tell it apart here. It's almost someone just swoosh a hand there and just made it very homogeneous. And ladies and gentlemen, in all purposes, that is what we call hypoxic brain injury. Okay, typically seen in very small kids or patients that had severe trauma and they couldn't get a good supply of blood to the brain for a bit of time, or there is a beta asphyxia, hypoxic brain injury. There is loss of the white matter and gray matter differentiation. Okay, and the final thing that I'll add here, this is a common thing seen in traumatic brain injury. You see these spots. Okay, are you seeing these spots? Okay, they are hyperdense, so we think it's definitely blood, but they are small. They are just small bleeds. Okay, what we call contusions. Okay, so these small bleeds, the moment you see them multiple like that, that is the diagnosis of what we call axonal brain injury. Okay, these are just bonus things that I'm adding. See multiple pactate, what we call pactate bleeds. Okay, that you're seeing all over the brain. That's what we call axonal brain injury. Okay, so ladies and gentlemen, that concludes the end of the interpretation of CT in general surgery and neurosurgery. I thank you.